Greetings from Rwanda to everyone. I'm Charles Ingabire. I work for IDEA Central Africa and I'm based at Rwanda Military Hospital. My presentation is titled Impact of HIV Stigma on Engagement in Care and Treatment, which is a qualitative study done in Rwanda. Starting from July 2016, Rwanda implemented its treatment guidelines to initiate ART for all people living with HIV within 7 days of a diagnosis. Studies in sub-Saharan Africa have found that stigma impacts health-seeking behaviors, engagement in care, and adherence to treatment, but few of them examined it in the context of treatment. We therefore aimed to quantitatively explore the impact of HIV stigma on patient engagement in care within treatment context. In order to achieve our aim, we conducted a secondary analysis of qualitative interview data from a study examining barriers and facilitators of antiretroviral uptake and treatment in Rwanda. We analyzed interviews from 37 people living with HIV who were at least 18 years old and were receiving HIV care from 2 health centers. For the current study, a team of 3 analysts reviewed all transcripts to identify stigma-rich contents and developed a codebook, then applied the codebook to the data using deduced software to identify emergent themes. We found 6 major themes: persistent negative societal perception of HIV. Those are the information that were true in the past but still exist in the community as true while they are not. Treatment as increasing visibility, meaning that the participant felt like the art itself or waiting in the health center exposed their status. We also found, anticipated, and experienced the stigma, psychosocial support, treatment seen as normalizing HIV and the art, and engagement in care. This is the stigma model that emerged through our findings, which present stigma pathways between the treatment and engagement in care. The green arrows represent positive impact, while red arrows represent negative impact. On one pathway, treatment can increase visibility of HIV through the medication itself as a sign of HIV infection, or by being seen in the health center. This led to anticipated stigma that could negatively impact engagement in care. On another pathway, treatment, through increasing the number of people in treatment, helped the participant realize that life can be normal after becoming HIV positive and taking medication. Expected bad things didn't happen and the patient stayed healthy. This experience can chip away at the persistent societal negative HIV perceptions and promote successful engagement in care. Our take-home message is that treatment has potential negative and positive impact on HIV-related stigma. On one side, study participants described increased visibility of their HIV status and exposure to potential stigma. In attempts to cope with those stigma experiences, they avoid disclosure of their HIV status at all costs, some foregoing care and putting their health at risk. On the other side, treatment normalized HIV and the use of art. This allowed participants to engage in early treatment and thus stay healthy and enjoying improved health. Overall, we hypothesize that treatment can destigmatize people living with HIV and reduce stigma. In order to support its potential positive impacts, HIV program and messaging should raise awareness of treatment, promote messaging like U equals U, and encourage disclosure as ways to reduce persistent negative societal perceptions about HIV and people living with HIV that are the source of different types of stigma. Lastly, we express much gratitude to study participants and everyone involved in this study, mentors, or NIH centers as funders, and to you all for your kind attention. Thank you.